You know, 20 years ago when I developed this brace, I had no idea the power it could have over the lower extremity. And we're going to show this particular patient case presentation towards the end, but to see this profound of a change in someone and the effect it has on their life and their quality of life truly is the most gratifying thing I've ever done in clinical practice. So it's a privilege to be able to share some of the experience with you tonight. I'm going to review just briefly the critical anatomy and the pathomechanics of the adult acquired flat foot deformity. I'm going to go over some essential patient examination techniques. I'm going to show you how to select the proper brace and, more importantly, how to prescribe the brace with certain enhancements and modifications. And then we're going to review essential steps for positioning the patient for casting and scanning. So I want to point out one thing that we've learned from evaluating and treating patients with flat feet is that not all flat feet are the same. This is a patient who has obviously bilateral, severely pronated feet and a flat foot arch profile, but he's a 65-year-old marathon runner and he has relatively no symptoms. He does not need a Richie brace. This is a 68-year-old female with a unilateral flat foot deformity with a debilitating pain and disability, and she needs a Richie brace. So the question is, what is the difference between these two patients? Well, we're going to go back and look at the pathology, which we now call adult acquired flat foot, previously called posterior tibial tendon dysfunction. And the adult acquired flat foot is more than just a rupture of the posterior tibial tendon. As we've learned, it's a progressive ligamentous rupture of key ligaments on the joints of the arch and the hindfoot. We've learned that this condition is a lot more prevalent than we ever thought. And a recent systematic review published in 2018 reveals what we've all learned, and that is, for some reason, this condition has a high preponderance for females. An interesting study published out of the UK in 2004 showed the high prevalence of posterior tibial tendon dysfunction, as it was called then. About 3.3% of middle to elderly patients get this disorder, and it's much more prevalent in women, and particularly in older women. And in this study, it was alarming that the vast majority of the patients that they screened had never been diagnosed or treated for the condition. The term adult acquired flat foot evolved from the previous term posterior tibial tendon dysfunction simply because the term posterior tibial tendon dysfunction is too limiting. It implies that the condition is entirely due to tendon rupture. But tendon rupture alone does not account for the progression of the deformity and the disability. Recognizing that ligaments rupture as well, researchers and clinicians coined the term adult acquired flat foot. And that's even changed more recently in the surgical setting to the term progressing collapsing foot deformity. Not so sure I agree with that. And for tonight's presentation, we're going to stick to the name adult acquired flat foot. In summary, if we look at the progressive steps of this, we know that the majority of patients who suffer adult acquired flat foot had a pre-existing flat foot condition all their life. We know from other studies that it places increased gliding resistance and friction against the posterior tibial tendon. The positioning of the hindfoot in an everted position unlocks the midfoot joints and places strain on key ligaments. These ligaments may rupture before or after the tibialis posterior tendon. But once the ligaments begin to rupture, we see structural change of alignment of the foot. If you would like more information on this, I've published 2 articles in the last 10 years. The first in Clinics Podiatric Medicine and Surgery in 2007. And then more recently, 2 years ago, in the same journal, I updated the biomechanics of adult acquired flat foot and also included orthotic treatment and ankle foot orthosis treatment. Also, there's a whole chapter in my book devoted to posterior tib or to adult acquired flat foot. And you're welcome to find that on springer.com. The ligamentous rupture of the adult acquired flat foot is what's key to not only our evaluation, but our treatment decision-making. Multiple studies beginning in the early 1990s began to discover this sequential ligament rupture that leads to collapse of the foot. The key ligaments are the spring ligament, the talocalcaneus interosseous ligament, and the deltoid ligament medially along the ankle. As these ligaments rupture, we begin to see bones shift. And one of the key steps is the rupture and attenuation of the superficial deltoid ligament, causing significant abduction and lateral shift of the calcaneus. The spring ligament is also a critical arch supporting ligament, and once it ruptures, leads to this significant transverse plane deformity. So we look at this foot on the patient's right foot, which is the left-hand side of the image, and we see this structural change and difference between the relatively flat but healthy left foot. One of the changes is the result of rupture of the superficial deltoid ligament, which is the only static support to prevent calcaneal eversion. In the adult acquired flat foot, this marked frontal plane eversion of the calcaneus is unlike anything we see in a juvenile asymptomatic idiopathic flat foot. But more importantly, as the interosseous talocalcaneal ligament ruptures along with the superficial deltoid, the calcaneus begins to impinge in the sinus tarsi of the subtalar joint and eventually against the actual fibula itself. That is why patients in stage 2 adult acquired flat foot present with lateral foot pain, not medial foot pain. And they are often misdiagnosed by clinicians unfamiliar with the disorder who think the patient may have peroneal tendonitis or perhaps even assume the patient has a lateral ankle sprain. If we do MRI studies of these patients, we see a lot of fluid edema in both the sinus tarsi and the lateral gutter of the ankle joint due to this impingement syndrome. Because the ligaments rupture and we lose connectivity between the midfoot, rear foot, and ankle, we've learned that a simple foot orthosis is not strong enough or powerful enough to affect the joint moments and decrease load on these critical injured soft tissue structures. And so what I'm about to show you then is how we stage the adult acquired flat foot and how we pick appropriate treatments based on the stage of the condition. So in order for us, we as clinicians to do this, we assess the stage of the deformity, which is really assessing the severity of the deformity. And what we're really doing is determining if ligaments have actually ruptured. We also need to assess muscle function, and we can do all of this in the clinical setting in less than 10 minutes time. We don't need x-rays, and we certainly don't need MRIs to come up with the proper diagnosis. So I'm going to take you through the weight-bearing assessment, and then we're going to go to the non-weight-bearing assessment. So after I take a history of the patient, I will bring them out into the clinic area where they can stand and walk for me, and I will examine them in stance and gait before I even lay a hand on them. And this allows me to get a general view of the severity of the deformity and the level of impairment, because when I watch them walk, I want to see if they're limping or if they're still relatively mobile. The first evaluation is from the posterior view, and here is a classic case where the patient has unilateral left side adult acquired flat foot, characterized by several findings. Yes, the calcaneus is more everted on the left foot, but look at the position of the medial malleolus. It has dropped inferior and it has rotated towards the camera. It is more posteriorly located towards the viewer than the healthy right foot. Finally, the forefoot on the left is more abducted, giving the so-called too many toes sign. Finally, a critical feature I want you to appreciate is that the tibia appears to be medially displaced over the calcaneus compared to the healthy right foot. The tibia and the talus are medially displaced in the transverse plane. If we took an X-ray, in this case of a right foot, appreciate this significant medial displacement of the tibia over the calcaneus, which is a key finding of the adult acquired flat foot. Made possible, by the way, by rupture of the deltoid ligament complex of the ankle. We view from the anterior, and we see this posterior shift to the medial malleolus and anterior shift to the lateral malleolus, and significant abduction of the forefoot on the rear foot, again compared to the left side asymptomatic foot. A different patient noticing the anterior shift of the lateral malleolus and the bulging of the talonavicular joint, and the subtle, more abduction of the forefoot on the rear foot. So we want to determine if this is a flexible versus a rigid deformity, and that really earmarks whether they're in stage 2 or stage 3. So in static relaxed stance, we simply try to supinate the already severely pronated foot. We can do this with a verbal cue, or we can manually invert the rear foot and try to bring the rear foot to perpendicular. If we can reduce the deformity, it is a flexible, reducible deformity. It is not rigid. It's a stage 2, not a stage 3. If I were to pick one test that's most valuable to detect ligamentous rupture of the midfoot, specifically the spring ligament, I would do the single foot heel rise test. And this is easy to perform when we're already out in the clinic floor. We've done gait analysis. We ask the patient to stop and grab onto a doorway, a doorknob, or something to stabilize themselves and perform this important test. In a healthy patient, when asked to stand on one foot, they can easily raise off the ground, and the heel is noted to invert as the heel comes off the ground. The heel should be able to come off the ground at least 6 centimeters. And the heel should also note to invert as it rises off the ground. In this case, the heel rises, but it everts, indicating a dysfunctional posterior tibial tendon. A healthy patient can do a heel rise because the midfoot joints are stable. The plantar flexury torque of the Achilles is translated to the metatarsophalangeal joints, and the entire foot as a rigid beam elevates off the ground. In the case of a ruptured spring ligament, the rear foot plantar flexes across the mid-tarsal joint because the midfoot joints are now unstable. We will see this so-called midfoot break, where there is significant plantar flexion of the rear foot on the forefoot. This is a visual confirmatory test of spring ligament rupture. Various levels of inability to perform the heel rise test are demonstrated, and you should always compare to the contralateral healthy foot. I always mention this because 95% of patients presenting with adult acquired flat foot have the condition unilateral. And this allows a good opportunity to compare to the contralateral healthy foot. My healthy patient who's run many marathons in his life has no trouble performing a single foot heel rise because he has healthy, strong ligaments across the midfoot joint. So his heel easily rises off the ground and there's no midfoot break, despite the fact that he has a flat arch. Another important test to do in the weight-bearing position and non-weight-bearing is the check for forefoot supinatus deformity. This was really first described by Beat Hinterman back in 1996, when he noticed that patients who ruptured their posterior tibial tendon had a peculiar finding in static stance. If he took the healthy foot and externally rotated the tibia and supinated the foot, he noticed it raised the arch of the foot, but the first metatarsal always stayed on the ground. But if the patient had ruptured the posterior tibial tendon and they externally rotate the tibia, the entire foot lifts off the ground. The first ray elevates off the ground, and there's no elevation of the arch contour. What Hinterman was really noting is the presence of a supination deformity of the forefoot relative to the rear foot. Patients with adult-acquired flat foot, when we correct the hind foot to neutral, we will see what looks like a forefoot varus deformity. But in this case, it's not a fixed forefoot varus, it's reducible. And we call this a supination deformity as opposed to a fixed varus deformity. Supination deformity is a compensation for a chronically everted rear foot during life. The more the rear foot everts, the more the forefoot has to invert to stay flat on the supportive surface. This was actually described way back in 1920 by Steindler, who discovered this interlinking relationship of rear foot pronation causing forefoot supination. And he called it the supinatory torque in the forefoot. This torque in the forefoot stretches out the ligaments and creates laxity. And as we correct the rear foot, we can easily push down on the first ray and bring the first ray back down to the ground. In a fixed forefoot varus, you cannot do this. So this is a supination deformity that has been acquired from the progressive deformity of the rear foot. It's reducible, and it should be reduced when we perform the casting for foot orthoses or for the Richie brace. It's hard to see the supination deformity when they're sitting supine in the examination chair. It's better to look for it when the patient is prone off weight bearing. I'd like to show you a video of a patient who has stage 2 adult acquired flat foot, and we have the patient in a prone position. We're placing the subtalar joint in a neutral position, and we see a significant inversion deformity of the forefoot to the rear foot. However, look how reducible it is. With just mild pressure over the dorsal aspect of the first metatarsal, we can reduce 20 degrees of forefoot supination to 0. That must be done when we cast the patient for the foot orthosis or for the Richie brace. The left-hand picture is of a similar patient with a high degree of supinatus deformity. And with gentle pressure on the first ray, we push down, and now we've reduced the deformity. We've actually restored an arch to the shape of the foot, and we've reduced what was 20 degrees of forefoot varus in the original cast to 0 degrees forefoot varus in the corrected cast. Some of you would say, how can you make that big of a change in a cast and expect the orthotic to be comfortable? And I will assure you, this will be a more comfortable orthosis and a more corrective orthosis than making an orthosis to an uncorrected cast. The lab, in order to balance out 20 degrees of forefoot supinatus, has to put such a large intrinsic balancing post in the cast, it will invert the device such to the point the patient literally slides off the foot plate. And when they slide off the foot plate, we lose control, the device is uncomfortable, and it begins to rub on the medial malleolus of the patient's ankle. Therefore, and I will show this towards the end of the presentation, we highly recommend reducing any forefoot supination deformity when we perform the impression casting technique for the Richie brace. Another very good test for spring ligament insufficiency was published by Chandra Pasapula. He's an orthopedic surgeon in England who has taken a great interest in the adult acquired flat foot. And he developed this test, which I think has great validity. I've used it many times on patients of my own, and it's very easy to perform. And by his studies, with cadaver studies, it absolutely detects a rupture of the spring ligament. You place the patient in a neutral position, off weight bearing, and you stabilize the lateral aspect of the calcaneus and cuboid with one hand. With the other hand, you push against the first metatarsal head, and you place your hand on the medial aspect of the forefoot and push it laterally. As you abduct the forefoot on the rear foot, you will feel an end point as the spring ligament tightens. In the case of a spring ligament rupture, you will see much greater excursion of the forefoot on the rear foot. You will see it and feel it when you compare the affected foot versus the contralateral foot. This helps confirm spring ligament rupture in a very profound visual presentation for both the clinician and the patient. So when we decide to treat the adult acquired flat foot, we want to perform what I call a three-dimensional approach. We want to invert the rear foot, we want to evert the forefoot, and we want to adduct the forefoot on the rear foot, particularly at the talonavicular joint. If we do all that, we will externally rotate the tibia and the talus on the entire foot itself. This is following a mechanism which we call the twisted plate mechanism of the human foot. It's been described by many people, but it's basically relying on the fact that forefoot pronation is linked to rear foot supination. And that's linked to external rotation of not only the talus, but the tibia. This was really described, and I love giving this lecture to the UK podiatrists, particularly my Irish friends, because this is all based on an Irish anatomist named McConnell, who published his findings in the Royal Irish Academy, the Proceedings of the Royal Irish Academy in 1944. And much of what McConnell wrote was the basis for my book in exploring pathologies of the foot, both in the rear foot and the forefoot. He is truly a big hero of mine. And in this original manuscript, he describes what he calls a twisted osteofibrous plate of irregular thickness of the bones of the human foot that undergo a degree of torsion for either stability or instability. That concept has been embraced by Kalikian and many other prolific writers and authorities around the world. McConnell's work was later republished by Basmagian and by Serafian 20 to 30 years after the original manuscript. But it basically is really pointing out the linkage between the tibia, the talus, the bones of the hindfoot and the forefoot, and really the establishment of the arches of the human foot. And it really shows how when we go from a pronated flat foot to a supinated high arched foot, it is a three-dimensional motion of multiple joints between the forefoot, the rear foot, and the tibia. And so we use that when we position the foot for casting and when we design a brace to limit excessive motion. When we implement a brace, particularly the Richie brace for adult acquired flat foot, our treatment goals are to eliminate pain as soon as possible. We want to restore mobility for the patient to get back to an active lifestyle, and we want to prevent progression of the deformity. Those are our three primary goals. And if we do that, we can avoid a very debilitating surgery. We have to tell patients that that's our goal. We have to tell them we're not going to cosmetically correct their foot. Their foot will always be flat. But what we want to do is take away the pain and allow them to ambulate pain-free so that they don't have progression of deformity and have to have a debilitating surgery. In my practice, I show patients what the surgery is to correct it. And when they realize the scope of the surgery, the risk and the long-term disability, they're much more willing to listen to the opportunity to wear a brace for up to 1 year to do the same thing as good or better than the surgery. We know from multiple studies that non-surgical treatment with AFO bracing is very successful. It has a very high likelihood of success. These are 7 studies published in the orthopedic and podiatric literature documenting and showing how various designs of AFO braces can restore an active lifestyle of patients and help them avoid surgery. For example, this study published by Alvarez in 2006, with a follow-up of 1 year, 80% of the patients were able to avoid surgery. And after 1 year of wearing an AFO brace, they were able to stop wearing the brace and remained pain-free. This is a recurring theme. These patients don't have to wear a Richie brace the rest of their life. We hope to have them out of the brace within 1 year. And the research verifies that. And my 20-year experience with the brace absolutely verifies that. Another very impressive study, follow-up of 8.6 years. Success was defined as being brace-free and avoiding surgery. 70% of patients were able to avoid surgery and stayed brace-free for 8 years. Very impressive. Another study published by a group of podiatrists in Pennsylvania, 87% of patients over a 27-month observation period were able to avoid surgery. Overall, if we review the literature, we can tell patients that the medical literature says 60% of patients in stage 2 adult-acquired flat foot will avoid surgery and will be able to discontinue their brace and stay healthy anywhere from 2 to 10 years later. That's a very positive outcome and goal for patients to realize, because if they know they can eventually move out of their brace, they're likely to be compliant with the treatment plan. We combine the brace with functional rehabilitation. We don't just have them wear a brace. They have damaged ligaments and they have a ruptured tendon. And just like with damaged ligaments elsewhere in the knee or the ankle after an ankle sprain, we must put them through functional rehabilitation to augment ligamentous healing. And we truly believe that ligaments can heal. This protocol was developed here in California by Cornelia Kulig, combining posteriotibial tendon strengthening as well as proximal hip top-down strengthening, as I'm about to show you. And in her case, adding balance training to the rehabilitation protocol. Again, a marked success rate. Over 50% of her patients were able to avoid surgery in stage 2 adult-acquired flat foot. Her paper was published in 2009 in the Journal of Physical Therapy. Her strengthening protocol involves simple use of TheraBand, strengthening the foot in the transverse plane movement of adduction with resistance. And then she looked at the hip, because we found that these patients, particularly the older women, were significantly compromised with proximal weakness, particularly in the hip, external rotators and abductors. And so most of the protocols that our therapists use out here for adult-acquired flat foot involve hip abductor strengthening, core strengthening, external rotation, and balance training. We know that most of these patients in stage 2 adult-acquired flat foot have significant balance disorder. You can see it yourself when you test them in the clinic. And so we try to restore balance with the same exercises we do for athletes after a lateral ankle sprain. And the patients tell you after the program that it was perhaps the most gratifying part of the whole program is they got their balance back. They feel more steady and their fear of falling has been significantly diminished. So we have these patients, depending on their level of stability, do the same balance training exercises that athletes do. They're just modified by the therapist based on the age and disability of the patient. So let's talk about the decision. When do we use a foot orthotic versus a Richie brace? And I will tell you in one simple sentence, if the patient cannot perform a single foot heel rise, it is unlikely that a custom foot orthosis alone will be a successful treatment for adult-acquired flat foot. If they can do a single foot heel rise, but they're already showing progression and deformity, I think it's fine to start out with an aggressive, traditional functional foot orthosis using some of the techniques that I'm about to show you for the prescription enhancement. This is a patient I treated with a early stage 2 adult acquired flat foot, simply with a foot orthosis and appropriate footwear. And in her case, I was successful. But the difference was she was able from the very beginning to do a single foot heel rise, so her spring ligament was still healthy. If they cannot perform a single foot heel rise, and the test that I showed you called the lateral push test is positive, we move them into a Richie brace. This is a classic case where the patient has bilateral flat feet, but the right foot is the symptomatic foot. I will often put their left asymptomatic foot in a traditional custom foot orthotic as a preventive measure to protect the unaffected foot, and we will brace only the unilateral symptomatic foot. We put them in motion control running shoes because they are optimal for the Richie brace. They have removable inserts. We pick shoes with motion control features that have dual density, medial posted midsoles to help further augment the pronation control of the Richie brace. In most cases, we prescribe for stage 2 adult acquired flat foot, the standard Richie brace. And this is the standard brace. It's an articulated custom foot orthotic foot plate articulated to lower limb supports with adjustable Velcro straps in both the anterior and posterior aspect to cinch the limb supports as tight as possible against the tibia and the fibula. The foot plate of the Richie brace follows podiatric principles of custom foot orthotic therapy to optimize position of the first ray, lock the mid-tarsal joint, and maintain alignment of the subtalar joint in a neutral position. We think that that's the magic of the Richie brace compared to traditional AFO braces, whereby our casting technique following the root neutral suspension technique is far superior than a partial weight bearing to weight bearing cast. We follow the principles of balancing the forefoot to the rear foot that has worked for over 50 years in the science of functional foot orthotic therapy. Locking the mid-tarsal joint is critical for stability of the forefoot and rear foot. The goal of our treatment, though, is three-dimensional. We want to restrain internal rotation of the tibia. We want to control that medial displacement of the talus that I showed you earlier. And we want to try to control abduction of the forefoot. We can do all of this with certain enhancements and designs of the Richie brace. This abduction of the forefoot on the rear foot is probably the critical level of the adult acquired flat foot deformity. The transverse plane component is unique to the adult acquired flat foot and dominates that deformity over any other part of pronation deformities that we see in other patients, including children with asymptomatic flat foot. The talonavicular joint is a difficult joint to control with foot orthoses. Foot orthoses that push hard against the talonavicular joint tend to be uncomfortable. And clinicians tend to form accommodations or pockets or soft spots because that area is just simply not tolerated by the human foot. But with an AFO, we can control the talonavicular joint more proximally by controlling tibial rotation. The talus is part of the tibia. It's locked inside the ankle joint mortise. It follows the tibial rotation. It has no muscular attachments. So as the tibia internally rotates, and as the fibula internally rotates, it carries the talus into adduction across the talonavicular joint. In order to abduct the talus, we externally rotate the tibia. So that's the design of the Richie brace, is to control rotation of the tibia in the transverse plane. And by tightening the limb uprights against the medial and lateral aspect, we can specifically control transverse plane rotation. Chris McLean did a study at the University of Massachusetts on a patient with posterior or adult acquired flat foot, and indeed, of all the kinematic features, the one that stood out the most was the reduction of tibial rotation, comparing the black line of the Richie brace to the unbraced condition. It was a significant controlling of internal rotation of the tibia. We also want to control the frontal plane displacement of the tibia and the talus over the calcaneus. And to do that, the brace pushes against the medial malleolus. This is a critical and tricky area because while we want to push against the medial malleolus, too much pressure here can cause irritation to the patient. But if we do it right, with gentle pressure here, we can add that third dimension of control. Besides just pushing under the calcaneus, we can push against the talus and push it laterally to try to correct alignment of the subtalar joint. These are studies done on articulated AFOs showing that an articulated AFO is more effective on adult acquired flat foot than a rigid solid AFO, but also articulated AFOs that have a lateral flange on the foot plate. And I'm going to show you why in just a moment. So when we stage the adult acquired flat foot, in stage 2, we recommend the standard Richie brace. Stage 3, we add the arch suspender. And in stage 4, the rigid non-reducible deformity, we go for the Richie gauntlet brace. So here's the standard brace, and this is the typical patient, unilateral, reducible, adult acquired flat foot. It's a unilateral Richie brace with a motion control running shoe. And if they're in stage 3, which is a more rigid, non-reducible deformity, we have the option of adding the arch suspender. The arch suspender is a powerful addition which provides a lifting strap to lift the arch of the foot, specifically at the talonavicular joint, allowing the patient to automatically adjust and correct on their own the subluxation of the talonavicular joint. And I'll show you a little bit more about it. Here it is. So the patient runs the strap up through a D-ring and secures the strap back down on itself, and it literally lifts the talonavicular joint for additional correction. Now you might say, well, that looks really good to me. Why wouldn't I do that with all adult acquired flat foot? I don't do that. I only use it for stage 3 severe collapsing flat foot simply because I don't need to in stage 2. And this imposes some challenges. As we provide the lifting strap, there's a tendency for the patient's foot to slide laterally. It requires you to also prescribe a lateral flange on the foot plate, and it may require some adjusting of the brace. That's all good for a stage 3, but I'm just telling you, you don't have to do the lifting strap on all patients with adult acquired flat foot. This is a severe collapse stage 4, where they not only have a rigid non-reducible deformity, but they've ruptured the deep deltoid ligament, causing the valgus attitude of the talus inside the ankle joint. This patient needs a rigid gauntlet. Their gauntlet is reserved for end stage, stage 4 adult acquired flat foot. And we do have a gauntlet that we provide, and we add the lifting strap to that we think is a powerful enhancement over the traditional gauntlets. Enhancements, which you can provide on the prescription form, and I'm going to go through these briefly. We recommend adding at least a 4 to 6 millimeter medial heel skive. We recommend, in many cases, adding a lateral flange. For heavier patients, we recommend upgrading to a 4.0 millimeter polypropylene shell. For heavier patients, rather than the standard stabilizing bar on the standard Richie brace, you can ask the lab, ask for Firefly to add a flat rear foot post. And for heavier patients, you may consider adding an arch filler with crate material, which will stiffen the entire foot plate. Finally, for severe forefoot abduction, you have the option of a forefoot strap. I'm going to take you through each one of these. The medial heel skive is well recognized as an enhancement on traditional foot orthoses to add a varus wedge effect to the shape of the heel cup of the orthosis. So a skive is applied to the positive plaster mold, and it literally creates a varus wedge to the inner side of the heel cup of the orthosis. For adult acquired flat foot, we would recommend 6 millimeters. I've had physicians go as high as 8 millimeters, and most of the time it's not a problem. We can actually add a skive or wedge effect to an existing Richie brace. If you're not getting the adequate control you're looking for, you yourself in the clinic setting can use Corex or EVA and create a varus wedge on the top cover of the Richie brace on the foot plate. In this case, I extend the wedge from the back of the heel cup all the way out to the navicular. This is a long extended medial wedge that is skived laterally and anteriorly, and a little bit of a wedge on an existing brace sometimes provides a powerful enhancement for additional pronation control when the patient's symptoms are not responding. We have the arch suspender, which we can add later if the patient is not improving. That can be added later, or it can be prescribed initially if you believe the deformity is already in stage 3 where it's more rigid and non-reducible. The arch suspender allows the patient to self-adjust and correct the talonavicular joint. But all of our strategies focus on the transverse plane when we're treating adult acquired flat foot, and control of the transverse plane relies on several levels of the bracing system. The first is the shoe itself. The shoe is critical to the entire bracing system. We can control the transverse plane by using a lateral flange on the foot plate, and we sometimes add even lateral forefoot wedging to prevent forefoot abduction. But don't forget the importance of the shoe. We will have clinicians take pictures of patients standing on their brace without the shoe, and they say the brace isn't controlling the abduction. We tell them, of course it's not. It relies on the shoe to help control that. We have to put them in a shoe that has a stable upper because the shoe is part of the transverse plane control. Once we put them in the shoe, the abduction of the forefoot disappears. But then we bring into the issue of flanges. And here is an interesting and almost controversial part of this lecture. Most clinicians think that adding a medial flange is a way to improve pronation control. And conversely, a lateral flange is a supination control. This seems to backfire when we look at the transverse plane instability of the adult acquired flat foot. Because when we look at the shape of the orthotic foot plate and look at the effect of flanging, we realize it creates a sloped surface. And in the adult acquired flat foot, it tends to make the forefoot pronate or abduct even more. The more we create a medial ramp, the more opportunity for the foot to slide off the ramp if it already is tending to abduct due to spring ligament rupture. And so in a lot of feet with adult acquired flat foot deformity, the medial flange, while it might improve surface area, actually induces a pronatory force against the forefoot. And so we have to be careful about applying medial flanges. And if anything, for adult acquired flat foot, I recommend a lateral flange, because a lateral flange acts as a wall or a mechanism to block forefoot abduction. So when we put on a lateral flange, it keeps the forefoot from abducting on the foot plate. It acts like a wall. Medial flanges tend to abduct the foot. Lateral flanges tend to adduct the foot. And don't forget about the importance of the shoe itself. So this patient's right foot, if we want to keep it from abducting, We want to put material against the lateral forefoot with an extended lateral flange. We want to block the lateral forefoot from abduction. So if I want to stop this foot from abducting, I put a lateral flange. So this is a left foot brace with an extended lateral flange, providing a wall effect. Here's a patient abducting in the forefoot. We put her in a lateral flange Richie brace, and we've corrected the abduction. Very simple. We don't worry about a medial flange. The Richie brace already has a 35 millimeter heel cup, which makes a very wide orthotic foot plate already. I'm just very leery about putting material up here in the midfoot that may cause abduction and sliding off the orthotic foot plate. There's a patient who was still abducting with a lateral flange, and we have the option of adding what we call a forefoot strap. So you can ask the Firefly to add a strap to the brace. They can actually ship you a strap and you can add it yourself. This is an add-on later. I don't routinely prescribe it ahead of time because it's rarely needed. The lateral flange normally works fine, but it is an add-on option for you to consider if there's still considerable abduction. Okay. So I'm going to quickly go through this so we don't run out of time. These are just common questions. Casting. I pointed out the importance of plantar flexing the first ray to remove forefoot supination deformity. We do this with foot orthotic casting, but with the Richie brace, the cast is a little bit different, and I'm going to show you. I'll quickly point out that we've got a lot of good education materials on the Richie Brace website. You go to www.richiebrace.com. There's at least 4 videos I've made showing the casting process with both plaster, STS casting sock, and with digital casting with the iPad structure sensor scanner. If you want to use good old-fashioned plaster, you can cast for a Richie brace by adding this one additional step. A single additional piece of plaster of Paris above the malleolus, and then applying the traditional slipper cast, you can cast for a Richie brace. We can make a Richie brace from a plaster cast as long as you add an additional strip of plaster that goes just above the malleoli. We prefer casting with the STS sock. This is also available. You can order this. It is a better, stronger, 3-dimensional model of the foot and ankle, but we still position the foot in subtalar neutral, and we plantar flex the first ray to reduce all forefoot supinatus deformity. Both the plaster cast and the STS sock must be marked at the medial and lateral malleolus and show us the distalmost tip of the malleoli so we know where to put the hinge axis of the Richie brace. This is all outlined very clearly on our Richie Brace website. I told you about removing the forefoot supinatus deformity. And let's talk about scanning. If we're going to scan for the Richie brace, I recommend putting the patient in a prone position because the scanner can capture the critical anatomy of the lower leg, the malleoli, and the plantar aspect of the foot much better than if the patient is supine. But we still have to pronate the forefoot on the rear foot, lock the mid-tarsal joint, and put the subtalar joint in neutral. We can't scan the foot just hanging in space. Therefore, it takes 2 people to perform the scan. I'm holding the foot the proper way. I'm using actually 2 hands to plantar flex the first ray and hold the forefoot pronated against the rear foot, while the assistant actually takes the scan using the iPad. You can't take a scan of the foot hanging in space. You will capture a severe supinated forefoot on the rear foot. You have to correct by pronating the forefoot on the rear foot. If you make a Richie brace from this cast or scan, you will fail. It will be an uncomfortable brace. The patient will slide off the foot plate and they will not tolerate the brace. So I'm going to just show you a couple case studies and then we'll take questions. People ask about footwear. I've recommended obviously wearing a lace-up athletic shoe. but we've had patients wear the Richie Brace in a variety of footwear, to my surprise. I've had patients wear it in hiking boots, in industrial work boots like you see here. Athletic shoes are preferred. And I'm gonna jump ahead and show you a couple of videos, and then we'll go forward, okay? So hang on, and we'll still have time for questions, okay? All right, here we go. Let me get rid of this. So this is on our Richie Brace website. You can show this to patients. It's a pretty dramatic video. This is a patient in stage 2 adult acquired flat foot, unilateral. She's in her 80s, very debilitated. Very typical. And then I'm going to show you with the brace. And it's pretty remarkable to see the three-dimensional change. If you really look at this, you'll see the improvement of forefoot abduction, just all aspects of the gait cycle. So here's an interesting case. This is a male patient, unilateral. Notice all those changes of severe forefoot abduction, the unilateral changes that dominate this deformity, particularly in the transverse plane. Yeah. And here he is wearing the brace in his work boots, and it works fine. He just leaves the boots a little looser in the upper because he doesn't need the upper of the boot anymore. He has the brace, but he's required to wear a steel-toed boot in the work setting. Look at the correction. Here's a patient. My practice is in a coastal community in Southern California, and I had a patient come in wearing his Richie Brace and a pair of sport sandals, and I was blown away by the control he was still getting in the brace, in the sandal. And I realized that the brace is held in place by the uprights. It's hard to wear foot orthotics inside sandals because the orthotic slides around. But when you wear the Richie Brace, it's secured to the leg. And as long as there are forefoot straps to control the forefoot abduction, this patient with adult acquired flat foot was very comfortable wearing the Richie Brace barefoot in a pair of sport sandals. Here he is without. Turn. Okay, and here's the patient I showed you earlier. She had a spinal cord injury causing both a drop foot and an adult acquired flat foot. She has a flaccid drop foot as well as severe collapsing adult acquired flat foot. I decided to put her in the arch suspender brace because it has a fixed hinge to control the drop foot. So it holds the ankle joint fixed at 90 degrees, and it has the arch suspender lifting strap to control that severe subluxing talonavicular joint. So here she is walking in the brace. Okay, ready, go. Now this woman walks 2 miles a day for exercise with her Richie Brace. The brace enabled her to go back to a full exercise regimen and a full active lifestyle, despite what appears to be a very debilitating foot and ankle neurologic and orthopedic condition. And like I said, there's really nothing more satisfying that you can see in something like that. So I'm gonna go ahead and open this up to questions and answers. I quickly want to point out that your go-to here is Firefly Orthoses. They've been a partner and provider of the Richie Brace for over 15 years. And they have a very capable staff of people who can answer a lot of questions regarding clinical indications, casting, prescription criteria. They're very well trained. Martin has worked very closely with me for over 15 years. And so they're a wonderful resource for any of you in the UK who want to order a Richie brace. If we have some viewers who are here in stateside, we have a list of distributors making the brace available in the United States that are also listed on the Richie Brace website, www.richiebrace.com. So with that, I'll go back to Connor and ask for any questions.
Thank you very much, Doug. A presentation that's full of clinical goals, and just to say thank you very much for your time and for delivering such an excellent presentation. As I said at the start of the presentation, if anybody has any questions, they can just raise their hand. You can press the little raise hand button either at the bottom or the top of your screen, and I will let you pose a question to Dr. Doug Richie. And we do have a question in the chat from Peter Gauntlet, and he says, with the rehab, can they get walking or get back to work immediately? And stepping up the rehab, increasing resistance, are you led by the pain level in the foot and the ankle? Yeah,
those are great questions. I'll answer the last one first, because pain absolutely directs all the treatment decisions. So the rehab program progresses with increased load, increased challenge based on pain. Getting back to work is absolutely based on pain. We don't see predictable pain response. It's not, basically, in my experience, on the level of deformity. I had patients who had severe deformity whose pain literally went away within hours of wearing the Richie brace. And I've had patients with relatively minor deformity who didn't have the pain go away until 4 to 6 weeks later. I do find that the patients who succeed with the Richie brace, for the most part, have their pain go away, or at least noticeably begin to go away within 2 weeks. If the pain hasn't gone away in any noticeable way after 4 weeks, it's not a good sign. It often indicates to me that I better immobilize them with some kind of a walking boot or a cast and completely quiet down the inflamed joints and try to start over with the Richie brace 4 to 6 weeks later. Fortunately, that's not real common. But I am amazed how many patients have almost immediate pain relief, and the majority significant pain relief within 1 month. The rehab program is a 6 to 8 week program, and it definitely needs to be monitored in the hands of a skilled therapist or rehab specialist to help with the decision making as far as the progression of the program.
Thanks, Doug. We have one other question from Sarah Jane Walls, and she asks, do you have the patient's rehab in their brace?
Oh, very good question. No. Most of those exercises are all done barefoot, including the balance training. Now, if they're really symptomatic, we will have them do the balance. You know, the exercises are non-weight bearing for the most part, and including most of the hip exercises. Any of the weight bearing exercise and the weight bearing balance training, if they're really symptomatic, they have to put on their shoes and wear their brace for it.
Okay, we have another question from Blanche Morrissey, and she asks, well, first of all, she says, what a great presentation. She says she is a patient who had a stroke and now has acquired flaccid foot, healthy, active man, early 90s, but desperately wants something done about his foot. He says his foot has a mind of its own. Would Richie brace be appropriate here?
Yeah, so the woman I showed you who's now walking 2 miles a day, she really presented much like a stroke patient. She had a flaccid drop foot, but also progressive adult acquired flat foot. Most strokes seem to affect the common peroneal nerve and the anterior musculature of the lower leg, meaning most strokes leave a flaccid drop foot. So the restricted hinge Richie brace, with or without an arch suspender, simultaneously addresses both the drop foot condition and the adult acquired flat foot. The only time I would be a little leery is if there's significant loss of push-off. If the patient has had loss of a significant strength loss of the gastroc and the soleus, they many times have to go into a carbon fiber AFO, a ground reaction AFO to restore that push-off phase. But fortunately, most stroke patients have strong calf muscles. They just have weak anterior muscles. So the restricted hinge Richie brace seems to work out fine.
A follow-up question from Sarah Jane. She asks, do you have any success with the brace in patients with rheumatoid arthritis?
You know, I've treated a number of patients with rheumatoid arthritis. As you know, the majority of them have their condition manifest in the forefoot joints, but I've seen severe rheumatoid arthritis in the subtalar joint. The problem in those cases, it's the inflammatory joint disease, not so much deformity that are the primary driver of the symptomatology and the disability. And usually we're just trying to stop motion. And so we sometimes go direct to a gauntlet brace rather than a standard Richie brace. And we may consider the Richie brace with an arch suspender with a restricted hinge. But we're really looking to limit motion in these arthritic conditions. And in inflammatory joint disease, you realize that the inflammation is coming from an autoimmune mechanism, not so much from a mechanical mechanism. So it can be challenging. However, and we may do this again, and I'm happy to do this for Martin, is we might come back and do another Richie brace workshop on arthritis, traumatic arthritis, post-traumatic arthritis of the hindfoot and ankle, that's not inflammatory from autoimmune disease, but is post-traumatic from an ankle sprain, where we've had tremendous success using the Richie brace for treating arthritis of the ankle, the midfoot joints, and the subtalar joint. That is a very gratifying area of intervention with the Richie brace.
Okay, don't be afraid to raise your hand so we can allow you to talk. One other question from Veronica Smith. She says, a great presentation. In stage 1 and 2, should the patient wear the brace for all activities up to 1 year?
Oh, that's a great question. Absolutely. They have to wear the brace the moment they get out of bed in the morning. You know, and this is something we overlook when we treat musculoskeletal conditions with foot orthoses, is we wonder sometimes when patients aren't getting better, and we don't stop and ask them, are you wearing your devices in the house? And a lot of them say, well, no, I don't wear shoes in the house. And you have to point out that this is just like wearing a cast when you have a fracture. The fracture is not going to heal if you walk around without the cast. The Richie brace is not effective if you're not wearing the brace literally 100% of the time that you're bearing weight on your feet, both in the house and outside. And that's why we point out that the brace can be worn in sandals. It can be worn in UGG type boots that are easy to slip on in the home setting. A lot of people have so-called home shoes that they wear indoors only. And you have to find suitable footwear for them to slip the Richie brace into easily at the bedside, literally before they get out of bed in the morning, and they wear it all day long. If they walk around for 10 or 15 minutes barefoot without the brace, they can offset a week of healing. I mean, we're trying to heal ligaments here, and ligaments heal, but the foot must be held in a stable position.
Can I ask my own question? Do you have evidence or examples of elite athletes using the Richie brace in football boots or cleats, as you might call them in the US?
Oh, yes. So early on, when I developed the Richie brace, it was meant as an athletic brace for lateral ankle instability. And we started marketing it to athletic teams at the collegiate level and even at the professional level. So we have to modify the brace, Connor, for that. We usually drop down the heel cup to, the normal range of 16 to 20 millimeters. We find a 30 millimeter heel cup often is too deep and challenging for football cleats. We tend to limit the forefoot extension of the brace. We may not put flanges on it, depending. But the bottom line is we can modify that foot plate to fit into a cleat just like you would a foot orthosis. And historically, we have a wonderful history here of the brace being used at the professional level. We have a whole story on our website of our National Football League, our form of American football. A top level athlete wore the Richie brace for a drop foot condition through a whole season in cleated footwear. And we have pictures of that and a video. It's pretty inspiring.
Okay, thank you for that. Martin, I don't know, do you have anything that you want to add? We're approaching 9:10 now. I don't want to keep people up all night.
No, just to say thanks to everybody for giving up their time, and thanks once more to Doug for the expertise. And maybe we will come back and do another presentation on the traumatic hind foot and ankle. That sounds like a good idea.
Sure.
And just to say to everybody who is here this evening, I will have a recording of the presentation for you in the morning. I'm sure many people will want to review it. There's just one other question that came in there from Jacqueline, and it says, thanks for the excellent presentation. Do you find patients are accepting of the leg support parts of the Richie brace if they are riveted into place, making them more rigid and so giving more control?
I think she's referring to the restricted hinge, which has double rivets that restricts ankle joint movement. It's remarkably well tolerated. You watch a patient walk in our restricted hinge brace and you see that they still have some ankle joint motion. I estimate it's about 5 degrees. So it's not as rigid as a solid AFO, which is quite, imposing for patients. So to answer your question, the restricted hinge is generally very well tolerated. It's just not always necessary. The vast majority of patients that presented in my clinical practice over 20 years, they got the standard Richie brace with full flexion hinge. I wasn't prescribing the restricted hinge that often. Certainly I used it for degenerative joint disease and used it for rigid stage 3. But, the full flexion hinge worked most of the time. You can always add the restricted hinge later, and you can always remove the restricted hinge and convert it to full flexion. So those are options for you if things aren't working out.
Okay, this is the very last question. I appreciate this is a great opportunity for people to ask Doug questions. So the very last question is, if a patient will not comply to the exercises for strengthening, is it still okay to try Richie brace?
Yes, I had patients who were non-compliant with the exercises, whether it was the cost, the inconvenience of going into the clinic, and they still succeeded. I just knew that the exercise greatly accelerated the healing and the prognosis, but I had many patients who didn't exercise who got better. So I wouldn't say that it's absolutely required. It's a nice enhancement, that's for sure.
Okay, Dr. Doug Richie, thank you so much for your time and for such an excellent presentation. We really appreciate it. And thank you to everybody for attending this evening. Martin, will I let you wrap things up? I'll just say as well, before we finish up, that Firefly's technical support team will also be on hand to answer any questions that you might have in relation to the prescription of the various braces from the Richie Brace collection. And they can be contacted at any stage via phone or email to answer any questions that you might have. So Martin, I'll leave it to you to wrap things up, and we'll
well, I think you've said it all there, Connor. I mean, we've been probably prescribing these for about 15 years, so we have a good wealth of information, and we can help people prescribe them. So if you have any queries, pathologies, when to use it, when not, the different types of braces, give us a call. And thanks to everyone. Thanks, Doug.
Thank you, Doug.
Bye-bye.
Good night, everybody. Take care. Bye-bye.